welcome to the deep dive. Today, we're taking a really fascinating journey, actually, into a less discussed area of vascular health, upper extremity aneurysms.
That's right.
We'll be drawing on the really extensive knowledge found in Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition, to guide us.
Yeah, it's a great resource. And you're right, we hear a lot about aortic aneurysms, don't we?
We do.
But it's easy to forget that whole intricate network of arteries in our arms and, the vessels leading to them. So this deep dive, it's really going to explore the surprising variety of aneurysms that can pop up outside the main chest and abdomen arteries.
Exactly. So our mission today really is to pull out the most critical info about these upper extremity aneurysms. What causes them, how they might show up, and what's new in treatment. We want to make it clear and engaging for you without getting totally lost in super technical jargon.
Good plan. And we should probably start with arch vessel aneurysms. They affect those major arteries branching off the aorta, supplying the head and arms. And interestingly, they're actually the most common type of upper extremity aneurysm we see.
Okay, let's unpack that then. Arch vessel aneurysms. So we're talking innominate, common, carotid, subclavian arteries. Right?
If I say those.
What makes these ones so significant? Why start here?
Well, the big one, the major concern, is the potential for a life-threatening rupture. That's always serious.
Right.
But even, short of that catastrophic event, these aneurysms can cause a whole cascade of other serious problems. Just think about the structures packed into that area. Stroke is a definite risk if clots break off and travel up to the brain. And local nerve compression, that can lead to some really unexpected symptoms like hoarseness or even brachial plexus palsy affecting the arm's function.
Hoarseness from an artery problem.
Oh.
Counterintuitive.
It is. But it happens. It presses on the recurrent laryngeal nerve. And then there's dysphagia, difficulty swallowing. That can happen if an aneurysm of an aberrant right subclavian artery, which we'll get into later, presses on the esophagus.
Wow.
Plus, patients might feel localized pain or, of course, limb ischemia if the arm's blood supply gets compromised. So, yeah, definitely not something to ignore.
Absolutely not. So, okay, let's look back a bit. How did we even start trying to fix these? It sounds like the early days were, well, a bit touch and go.
That's putting it mildly. A learning process, for sure, with significant risks. Back in the early 1800s, you had pioneers like Astley Cooper. He was trying to treat carotid aneurysms by ligation, basically just tying off the artery.
Tying it off.
Yeah. Then, 1818, Valentine Mott attempted to ligate the innominate artery for a subclavian aneurysm. Sadly, the patient didn't make it.
Oof. Yeah, high stakes back then.
Very high. The first successful treatment, though, for a subclavian aneurysm using ligation of the carotid and innominate came from Smith in New Orleans, 1864. But even then, the aneurysm came back about 10 years later.
So not quite a permanent fix.
Not always. The real breakthrough, arguably, was Halsted at Johns Hopkins in 1892. He successfully combined ligation with resection, actually removing the aneurysm for a subclavian case.
Okay, so getting the problematic bit out entirely.
Exactly. That was key. Moving from just stopping flow to actually removing the source of the problem and restoring flow. That's a cornerstone now. And then in 1913, Rudolf Mattes, another giant in the field, reported a big series using endoaneurysmorrhaphy.
Endoaneurysmorrhaphy.
Right, basically opening the aneurysm sac and repairing it from the inside. And importantly, 7 of his cases were subclavian aneurysms. So this history, it really shows that gradual but really significant progress in understanding and surgical skill in this tricky area.
Definitely shows the evolution. Okay, so who typically gets these arch vessel aneurysms today? And what's usually driving them?
Generally speaking, these aneurysms innominate, common, carotid, subclavian, they're usually due to degenerative disease. Primarily affects men, typically over 60.
Okay, degenerative.
Yeah, that's the main driver. But there's actually a surprisingly long list of less common causes, too. Things like trauma, fibromuscular dysplasia, that's a condition affecting the artery walls themselves, syphilis, cystic medial necrosis, different types of vasculitis.
Syphilis, still a factor?
Less common now, but historically, yes. Even invasion from nearby tuberculous lymph nodes or sometimes rare idiopathic congenital factors.
So quite a range.
It is. The key takeaway is while degenerative is common in older men, you have this whole list of other possibilities. So you need a broad differential, especially in younger patients or those with specific risk factors.
Makes sense. And you mentioned these aren't the most common peripheral aneurysms overall.
Correct. Subclavian and innominate aneurysms are a small slice of all peripheral aneurysms. But here's the important part. Many of these patients have other aneurysms elsewhere.
Ah, so it's a sign of a wider issue, potentially.
Exactly. Brownstein and his colleagues found a significant majority had multiple aneurysms, often involving the aorta itself. So if someone presents with an arch vessel aneurysm, it's a huge red flag to look carefully for others throughout their vascular system. You need a full workup.
Got it. One aneurysm warrants looking for more. Okay, let's zoom in specifically on subclavian artery aneurysms now.
All right, subclavian. As we said, the most frequent type of arch vessel aneurysm we encounter.
Right, so what's the breakdown of causes here? You mentioned degenerative, but what else?
So true subclavian aneurysms, not pseudoaneurysms, are often degenerative in older adults, like we discussed. Perilero's big study highlighted degenerative traumatic pseudoaneurysms and also those linked to thoracic outlet obstruction.
Thoracic outlet obstruction, that's the compression near the collarbone and first rib, right?
Exactly, compression of nerves and vessels there. Their research showed a mix. But interestingly, more recent data from Davidovit et al. Pointed to thoracic outlet obstruction as the leading cause in their series, a significant chunk.
So maybe the understanding is shifting a bit.
It seems that way. Maybe we're diagnosing TOS-related ones better now, or the pattern has changed. Then you have pseudoaneurysms. They often come from trauma, both blunt and penetrating,
Okay.
and increasingly iatrogenic injury. That's injury from medical procedures,
Huh?
especially attempts at subclavian vein catheterization, putting in central lines.
Right, central lines are so common now. Is there a specific risk there?
Yes. Smaller catheters you can usually manage with pressure after removal,
Mhm.
but the larger ones, like for hemodialysis, they create a bigger hole. And it's hard to compress that effectively because the clavicle's right there in the way.
Oh.
So that can lead to significant bleeding or pseudoaneurysm formation. The good news, though,
What's that?
endovascular techniques using stent grafts, closure devices, they've shown real success in treating these iatrogenic injuries. Less invasive solutions are becoming more common.
That's good to hear, especially for procedure-related issues.
Mm-hmm.
Okay, let's pivot to innominate artery aneurysms. You mentioned these seem less common, or at least less commonly repaired.
That's generally true. While Brownstein's review suggested a decent chunk of true arch aneurysms involved the innominate, defined as over 1.8 centimeter diameter, most surgical series report repairing far fewer. Usually only those bigger than 3 centimeter get operated on. Bauer's long-term series, for example, only had a handful of true innominate aneurysms treated surgically.
So a size threshold for intervention.
Typically, yes. And Kiefer's larger series found various causes beyond just degeneration, things like mycotic, meaning infection-related dissecting aneurysms, connective tissue disorders, also extension from aortic arch aneurysms, and of course, traumatic and iatrogenic pseudoaneurysms.
So when they do occur and need fixing, the reasons can be quite varied.
Exactly. Quite diverse.
What about the common carotid artery? You said true aneurysms there are pretty rare.
Very rare, yes. True aneurysms of the common carotid are uncommon. Pseudoaneurysms are much more frequent in that location, often complications from prior carotid surgery, trauma, dissections, or infections.
So false aneurysms are the main issue there.
Mostly. The true ones that do happen are usually degenerative, but sometimes linked to rarer things like fibromuscular dysplasia, Marfan syndrome, Behçet disease, Takayasu arteritis, basically conditions affecting blood vessels systemically.
Okay.
And getting bilateral common carotid aneurysms, extremely rare, usually linked to Takayasu or maybe Coogan syndrome. It's also worth remembering that aneurysms right at the carotid bifurcation or in the internal carotid artery are kind of considered a separate thing.
Right, location matters within the carotid system.
Hmm.
Okay, so with all these different types and locations, how do these arch vessel aneurysms actually, well, make themselves known? What are the signs and symptoms?
It's interesting, actually. With the rise in medical imaging, CT scans, MRIs, many arch vessel aneurysms are found completely by accident, incidentally discovered.
Ah, found while looking for something else.
Exactly. Only maybe a quarter of patients actually have symptoms when they're diagnosed, but when symptoms do occur, they really vary depending on where the aneurysm is and what it's pushing on or affecting nearby.
Makes sense.
You might get chest, neck, or shoulder pain, often from rapid expansion or even rupture. Thromboembolism, clots breaking off, can cause both acute and chronic ischemic symptoms in the arm.
Reduced blood flow.
Right. Compression of the brachial plexus can cause arm pain and neurological problems. And like we mentioned, hoarseness from recurrent laryngeal nerve compression, or breathing difficulties if it compresses the trachea.
It really is like a domino effect based on location.
It absolutely is. Clots traveling into the vertebral or carotid arteries can cause TIAs, mini strokes, or full strokes. Dysphagia, the swallowing difficulty from esophageal compression with an aberrant right subclavian artery aneurysm. And in really rare cases, erosion into the lung apex can even cause hemoptysis, coughing up blood.
Wow.
And if a fistula, an abnormal connection, forms between an arch vessel and the airway or esophagus, that brings its own set of serious symptoms. Lastly, those iatrogenic pseudoaneurysms often present as a pulsating mass, potentially causing airway or nerve compression, chest pain, limb ischemia, or even making the patient unstable.
That's a huge range of potential problems. What about physical signs? What might a doctor actually find during an exam?
Well, in asymptomatic cases, like we said, it's often the imaging finding. For subclavian artery aneurysms specifically, a patient or doctor might notice a pulsating lump just above the collarbone in the supraclavicular area.
A visible pulse there.
Possibly, but it's important to remember just a tortuous, meaning unusually twisty but otherwise normal carotid or subclavian artery, is actually a more common cause of a palpable pulse there than a true aneurysm.
Good point. Need to differentiate.
Definitely. Other signs could be a supraclavicular bruit, that's an abnormal whooshing sound heard with a stethoscope over the area, or absent or weakened pulses in the arm. Sometimes pulses might feel normal, but you see signs of microembolization, like blue finger
A
syndrome.
little clots traveling down.
Exactly. And then signs related to compression, brachial plexus issues, vocal cord paralysis, Horner syndrome.
Horner syndrome. Remind me.
That's the drooping eyelid, constricted pupil, and decreased sweating on one side of the face. It's due to nerve compression in the neck or upper chest.
Right, right. So a mix of symptoms and signs can raise suspicion. How do you actually confirm it and figure out the details for treatment planning?
Imaging is absolutely key. A plain chest x-ray might show an upper chest mass, which could be an aneurysm, but could also be a tumor or something else.
So not specific enough.
Not really. Ultrasound, MRI, or CT scans are what really nail the diagnosis and give more detail. But critically, you need angiography. Either conventional catheter-based angiography of the aortic arch and upper extremities, or CT angiography, CTA, or MR angiography, MRA.
Why angiography specifically?
Because these techniques precisely define the aneurysm size, its exact location, whether there are blockages in other vessels. They assess the health of the vertebral artery on the other side, which is vital if the aneurysm involves one vertebral origin. And really importantly now, they evaluate if the anatomy is even suitable for an endovascular repair.
Planning the approach.
Exactly. All that detailed info is crucial for deciding open surgery or endovascular, and exactly how to do it.
Okay, let's get into those options. Starting with open surgical repair. What's the general game plan when operating on these arch vessel aneurysms?
The fundamental surgical approach is either resection, cutting out the aneurysm, or that endoaneurysmorphy technique, opening the sac and repairing from inside. Either way, the goal is always to reestablish continuous blood flow through that artery.
Got to keep the blood flowing.
Absolutely. For very small aneurysms, maybe you can do a direct end-to-end connection, sewing the healthy ends together. But more often, you need an interposition graft.
A graft, like a replacement tube.
Exactly. Usually a synthetic tube or sometimes a vein graft used to bridge the gap after the aneurysm is removed or excluded. Now, historically, sometimes they just ligated, tied off the artery on either side, but that's generally avoided now.
Why is that?
Because ligation alone carries a pretty significant risk, maybe 25% of causing ischemic symptoms in the arm afterwards, reduced blood flow.
Right. Solves one problem, creates another.
Precisely. So some form of reconstruction to maintain flow is almost always necessary.
Makes sense. Let's talk specifically about innominate artery repair. You mentioned a classification system earlier.
Yes, Kiefer and his colleagues proposed one. It helps guide the surgery based on anatomy. Type A is when the aneurysm is just on the innominate artery itself, distal to where it comes off the aorta. Type B, the most common, involves the innominate and its origin from the aorta, but not the aorta itself. And type C is the most extensive, involves the innominate and the ascending aorta.
Okay, so different levels of involvement. How does that affect the surgery?
For types A and B, the exposure is usually a median sternotomy incision down the breastbone, often extended up into the right side of the neck.
Opening the chest?
Right. This gives access to the innominate at its origin from the aortic arch. Then you carefully find and control the subclavian and carotid arteries further out. After the aneurysm is resected, you reconstruct, usually with a prosthetic graft. For A and B, the graft typically gets sewn onto the healthy ascending aorta just before the innominate origin. Then the other end connects to the healthy distal innominate artery. The original opening on the aorta is sewn shut, maybe with a patch for reinforcement.
So the classification really dictates the extent of the repair.
Exactly. Knowing if it's just the vessel, type A, versus involving the aortic origin, type B or C, hugely impacts the approach and complexity.
What if the aneurysm involves where the innominate splits into the subclavian and carotid?
Good question. If the origins of the right subclavian or common carotid are involved, you might use a bifurcated graft, a Y-shaped one. One limb goes to the subclavian, the other to the carotid. Or you could sew a single graft to the common carotid, then attach a smaller branch graft off that, leading to the subclavian. Surgeons have to be careful with bifurcated grafts, though, to avoid kinking when closing the chest. So the connection to the aorta is often made on the side of the ascending aorta.
Little technical details matter.
They do, and if the patient has a bovine arch, that's a common variation in how the arch vessels branch, you might need an extra graft to the left common carotid too. And for those big type C aneurysms involving the ascending aorta, that's major surgery. Usually requires complete replacement of the aortic arch and innominate artery with a graft. That means cardiopulmonary bypass and often hypothermic circulatory arrest to protect the brain while the work is done.
Wow, that is definitely complex. Okay, what about open repair for subclavian artery aneurysms? Are there different approaches here too, depending on location?
Yes, definitely. Subclavian aneurysms are often thought of as proximal, usually degenerative or distal, often linked to that thoracic outlet syndrome.
Right.
For proximal right subclavian aneurysms, you often need that median sternotomy again, maybe extended up above the collarbone, to get good control near the origin. Sometimes incisions above and below the collarbone are used to mobilize the artery. Occasionally, taking out part or even the inner third of the clavicle gives great exposure, though partial removal is more common if a full sternotomy isn't needed.
Removing part of the collarbone.
Temporarily, or sometimes permanently, for access. For proximal left subclavian aneurysms, it's often a left thoracotomy incision through the side of the chest, maybe combined with an incision above the clavicle. In some very specific cases, you might do an extra anatomic reconstruction, rerouting blood flow around the aneurysm with a graft from another artery and tying off the aneurysm itself.
Okay, and for aneurysms further out, mid or distal subclavian?
For those, an incision just above the collarbone often works, maybe with one below it too, for better control further down. Endovascular balloon catheters can also be used here, guided by imaging, to temporarily block flow above and below while operating.
Less invasive control.
Exactly. If you need more room, the middle part of the clavicle can be temporarily divided or taken out, then put back together carefully afterwards. And crucially, if the aneurysm involves the origin of the vertebral artery supplying the back of the brain, you have to reconstruct it, reimplant it, usually, especially if it's the dominant vertebral on that side.
Can't compromise brain flow.
Absolutely not.
So, lots of tailored surgical techniques. What are the results like for these open repairs? Are they durable?
Generally, yes. Resection with graft replacement tends to be a very durable solution. Excellent long-term results. Paralero's series, one of the larger ones, showed sustained arm circulation without procedure issues over many years of follow-up.
That sounds good. But are there downsides?
There are. Despite good long-term outcomes, open repair can come with significant morbidity, even mortality. Kiefer's series on innominate aneurysms, for instance, reported a notable in-hospital death rate, and many patients needed prolonged ventilator support after surgery.
That's serious.
It is. Remember, many patients with true aneurysms are older, often have other health problems, making them less ideal candidates for major surgery. So careful patient selection for open repair is absolutely critical to get good outcomes.
What makes someone a poor candidate?
Relative contraindications might include really poor lung function, having had a previous sternotomy or left thoracotomy, or being hemodynamically unstable due to multiple injuries.
Okay. Given those risks, especially in higher risk patients, it makes sense why endovascular repair has become more appealing.
Absolutely. Endovascular repair using catheters to place stent grafts inside the vessel generally has lower rates of morbidity and mortality compared to open surgery.
Less invasive.
Much less invasive. Over the last decade or so, we've seen many more reports on using it for arch vessel aneurysms, especially innominate and subclavian. It's even being used now in some patients who could be okay surgical candidates, just to avoid the bigger operation.
Interesting. Any specific advantages beyond being less invasive?
Well, potentially for aneurysms related to connective tissue disorders. It avoids having to cut and sew on those inherently weak diseased vessels, though we're still gathering long-term data specifically on how well these grafts hold up in those conditions.
Right. Long-term durability is key. So anatomically, what makes someone a good candidate for an endovascular fix in this area?
Generally, the proximal and middle parts of the subclavian artery are the most suitable spots.
Okay.
But there are limitations. Often these true subclavian or innominate aneurysms don't have good landing zones.
Landing zone.
Healthy segments of artery above and below the aneurysm where the stent graft can seal properly. Without good zones, it might not work or could leak. Also, covering important branch vessels can be a problem, like the right carotid, the vertebral arteries, or the left internal mammary artery, especially if it's being used for a heart bypass graft. You might not want to block those off.
Can't compromise other important flows.
Exactly. And endografts crossing the first rib, they can get compressed from the outside. The distal subclavian artery, in that tight space between the clavicle and first rib, is particularly tricky. Stent grafts there can get squeezed, bent, even fractured over time.
Mechanical stress.
Right. Another potential issue, specifically with stenting the right subclavian, is the risk of stroke if debris gets knocked loose into the right common carotid during the procedure. And the origins of the vertebral arteries are vulnerable too. Easy to accidentally cover them with the stent graft.
What happens then?
Well, if the other vertebral artery is healthy and can compensate, it might be okay. But if the contralateral artery is narrowed, blocked, or underdeveloped, covering the origin can cause a posterior circulation stroke.
Serious consequence.
Very. In those cases, you might need to revascularize the vertebral artery first, maybe connect it surgically to the common carotid. Or if the aneurysm involves the vertebral origin itself, you often embolize it, block it off with coils to prevent leaks into that branch later.
So incredibly careful planning is needed, considering all the nearby plumbing.
Meticulous planning is paramount. You need to know the exact anatomy, the flow dynamics, everything.
Okay. What's the actual technique like for these endovascular repairs? How do they get the stent graft in?
Access is usually through an artery, most often the brachial artery in the arm or the femoral artery in the groin.
Arm or leg access.
Right. Less commonly, maybe through the axillary artery under the armpit, or even the carotid artery in the neck. Both balloon-mounted and self-expanding stent grafts have been used, often off-label.
Off-label.
Meaning used for a purpose not specifically approved by regulatory bodies, but based on physician judgment and available data. Common grafts include names like Wallgraft, Viabond, Fluency. The delivery sheaths, the tubes used to get the graft there, are usually around 7 to 9 French in diameter, fairly small. But bigger aneurysms, like in the Innominate, might need larger sheaths.
Different grafts for different situations.
Oh. Yes. Viabond, for instance, is more flexible, so it's good for navigating tortuous, bendy arteries. Newer, lower-profile options exist too, like the iCast and VBX, which are balloon expandable and can go through smaller sheaths. Some can even be expanded quite significantly after placement. Exactly. And because the artery diameter might change above and below the aneurysm, sometimes you need to combine different sizes or types of grafts to get a good seal. Maybe a more rigid balloon-mounted graft proximally for precise placement combined with a more flexible self-expanding one distally.
Tailoring the tools to the job. You also mentioned hybrid operations. What does that mean in this context?
Hybrid means combining open surgical techniques with endovascular ones in the same overall treatment plan.
Okay, best of both worlds.
Potentially. One example. Say you have a proximal subclavian aneurysm, but it doesn't involve the very origin from the aorta. You could embolize it, block it off with coils, or a vascular plug endovascularly. Then you do an open surgery, either a subclavian transposition, moving it, or a carotid subclavian bypass to restore flow. This avoids putting a stent graft in the aneurysm itself.
Ah, I see. Block it off, then bypass it.
Exactly. And to make sure it's fully excluded, you'd often surgically tie off the subclavian artery between the aneurysm and where the bypass connects. These can be done in stages or all at once in a hybrid OR with advanced imaging.
Still need to protect those key branches, right?
Always. Careful attention to the vertebral artery, especially if the other side is iffy, and the left internal mammary if it's needed for coronary bypass, now or potentially later. It's all about tailoring the approach.
Makes sense. And you mentioned using iliac limb endografts off-label too. How does that work?
Yeah, that's another hybrid technique, sometimes used for right subclavian or innominate aneurysms. Surgeons might use an iliac limb endograft designed for the leg arteries in combination with a carotid subclavian or carotid axillary bypass. The endograft gets introduced backwards, retrograde, into the innominate artery, often using the bypass graft itself as the access route before it's finally connected to the subclavian.
Wow, that sounds intricate. Any specific risks?
The main worry there is cerebral embolization knocking debris loose towards the brain. So specific steps are taken, like temporarily blocking flow in the carotid while deploying the graft.
Okay. And with thoracic aortic endografts becoming more common for aortic issues, are they playing a role here too?
They absolutely are. Hybrid procedures are increasingly useful for those great vessel aneurysms that extend further back into the aortic arch itself. The idea is to use a standard thoracic endograft debar to cover and exclude the opening of the aneurysmal arch vessel from the aorta, but then you'll need to combine that with extra anatomic revascularization of those arch vessels, basically rerouting the blood supply. Exactly. It might involve completely debranching the vessels from the ascending aorta and creating bypasses like carotid to carotid, subclavian transposition, carotid subclavian bypasses to keep blood flowing to the head and arms after the main origin is covered by the TEVAR graft.
So a major rerouting combined with the endograft.
Precisely. It allows treatment of complex arch anatomy without necessarily needing that massive open arch replacement surgery we talked about earlier.
Okay. With all these different endovascular and hybrid options emerging, what are the outcomes looking like compared to the traditional open repairs?
It's a bit tricky because arch vessel aneurysms are pretty uncommon, right? So most of the data on endo and hybrid repair comes from smaller case series or individual reports.
Limited data pool.
Exactly. For the non-atherosclerotic ones, connective tissue disorders, Takayasu infections case reports often show good short-term results. But you always have to consider potential publication bias. Successful cases get reported more often. And the long-term durability of these grafts in the dynamic arch environment is still something we're watching closely.
Makes sense. Any larger reviews?
A systematic review by May et al. Looked at endovascular treatment for subclavian aneurysms. They found very low procedure-related death rates and high technical success. Short-term patency, keeping the stent graft open, seems pretty good, often reported between 83% and 100% over several months.
But what about complications?
They do happen. Things like endograft compression, bending, fracture, or narrowing from scar tissue buildup, intimal hyperplasia, have been reported. These could affect long-term function. Bruin's series, using that hybrid carotid axillary bypass with retrograde iliac limbs, showed good patency, but they did have a couple of minor strokes. Curie's Cleveland Clinic series reported low mortality and no endoleaks or aneurysm growth, but didn't detail specific patency rates. Anderson's series on hybridendo for intrathoracic subclavian aneurysms reported some mortality and stroke. Other series on extracranial carotid aneurysms treated with covered stents, and a big review by Leo et al. Showed reasonable success, but also reported rates of mortality, stroke, endoleaks, and the need for reintervention later on. Zem's series on subclavian endo repair showed good midterm patency, but again, some needed more procedures.
So overall?
Overall, the small series show encouraging results. Endovascular and hybrid approaches seem promising, especially for reducing immediate surgical risk, but long-term data and understanding potential failure modes are still evolving.
Okay, let's shift gears now to something quite specific and interesting. Aneurysms of an aberrant subclavian artery and this comoral diverticulum. Sounds like it starts with a congenital variation.
It does indeed. An aberrant right subclavian artery, or RRS, is actually the most common congenital anomaly of the aortic arch. Affects maybe 0.5% to 1% of people.
So not that uncommon.
Relatively speaking, no. It was first described way back in the 18th century. Normally, the right subclavian comes off the innominate artery. In RSA, it arises directly from the descending thoracic aorta, usually distal to the left subclavian artery. Most often, maybe 80% of the time, it then crosses behind the esophagus in front of the spine to get over to the right side.
Behind the esophagus.
Usually. Less commonly, it might go between the esophagus and trachea, or even in front of the trachea. If someone has a right-sided aortic arch, you can get the mirror image, an aberrant left subclavian. It's all down to how the aortic arches develop embryologically.
And most people with this don't even know it?
Exactly. Most are completely asymptomatic. It usually has no clinical significance. An interesting association, though, is a non-recurrent right laryngeal nerve often goes along with it.
Okay, so when does it become a problem?
Aneurysmal degeneration of the ARSA is seen most often in adults over 50. And when an aneurysm does develop there, most cases end up needing intervention, either because they're causing symptoms or because of the rupture risk.
Is there a size cutoff for repair, like with other aneurysms?
It's less clear because it's rarer, no definitive guidelines. But some experts suggest considering repair if it's over 3 centimeters in a patient who's a good surgical candidate. Data from a multi-center registry showed the average size at presentation was actually over 4 centimeters.
And this coronal diverticulum, how does that fit in?
The coronal diverticulum is basically a degenerative aneurysmal bulge or outpouching right at the origin of the aberrant subclavian artery, where it comes off the aorta. It's seen in up to 60% of people with RSA, named after Komarov, who described it in 1936. Its clinical significance was highlighted later, in the 50s. Vinicota and colleagues published the largest experience recently, looking at both surgical and endovascular treatments over almost 20 years. So it's that pouch at the origin that can become aneurysmal itself.
Got it. So the diverticulum itself could be the problem area. How do these aberrant arteries, with or without aneurysms, actually present clinically?
For a non-aneurysmal RSA, Kiefer's classification helps. Some patients get compressive symptoms, mainly dysphagia, difficulty swallowing from the vessel pressing on the esophagus.
Dysphagia lusoria, right?
That's the classic term, yes. Others might develop occlusive disease in the aberrant artery itself, leading to arm ischemia. Kiefer's group found a good number presented with swallowing issues, others with reduced arm blood flow from blockages or clots. More recently, Stone et al. Confirmed many are asymptomatic, but others present with dysphagia, ischemia, or signs of an aneurysm. They actually observed some patients without immediate intervention and found many did okay over time without complications.
So not everyone needs immediate treatment if it's just the aberrant artery without an aneurysm.
Not necessarily, especially if asymptomatic. But what about when an aneurysm is present?
Right. What happens then?
Well, sometimes they're still found incidentally. They usually present with symptoms, often related to compression dysphagia or dyspnea and cough from tracheal compression. Chest pain from expansion or rupture is common, or symptoms of right arm ischemia from thromboembolism.
And rupture is a real risk.
Definitely. They can present as an emergency with rupture or dissection. One registry reported rupture in about 14% of cases, and Sina's series found over 50% presented with rupture or dissection. And interestingly, the rupture risk doesn't seem closely tied to the aneurysm size in these cases, unlike typical aortic aneurysms.
That's concerning. Size isn't necessarily predictive.
It seems less so here. Vinicota's series on coronal diverticulum found dysphagia, dyspnea were most common, then chest back pain. No embolic issues at presentation in their group. Sometimes the first clue is just a superior mediastinal mass on a chest x-ray.
Oh.
CT can detect it, but you really need CTA or conventional angiography for planning treatment. And about a fifth of these patients also have an abdominal aortic aneurysm, so you need to look for that too.
Another reason for a broader vascular workup. Okay, treatment. What's the approach for these aberrant subclavian arteries and their aneurysms?
For asymptomatic patients without a coronal diverticulum, conservative management, just watching, is usually okay. No specific surveillance guidelines, but if symptoms develop or an aneurysm forms, then treatment is needed.
And for symptomatic ARSA without a big aneurysm?
Open repair is common, usually through an incision above the clavicle. The artery is divided over on the left side of the esophagus, and the distal end is moved over and sewn onto the side of the right, common carotid artery. Just ligating it can sometimes relieve the pressure symptoms, too. This works well if the proximal part, the origin, isn't aneurysmal.
Okay. But if there is an aneurysm, especially near the origin,
then resection or exclusion with reconstruction is generally recommended because of the symptom risk and the potential for lethal rupture.
Can't leave that risk.
Exactly. The best approach depends on the anatomy, the patient's fitness, how urgently they need treatment. Elective open repair might be staged. First, create an extra anatomic bypass for the subclavian, then do a thoracotomy, open the chest to oversew the coronal diverticulum origin at the aorta. Sometimes you can just clamp the origin, but often, if the aorta itself is involved, you need to resect a segment of aorta and replace it with a graft. It's similar thinking to repairing a proximal left subclavian aneurysm. Thoracotomy or sternotomy might be needed.
Complex open surgery again.
It can be. Reconstruction options include grafting to the ascending aorta, or doing the resection via left thoracotomy and then connecting the subclavian to the carotid via a right neck incision. Staging it during the bypass before the thoracotomy is often preferred to reduce the risk of clots traveling to the brain or arm during the main procedure. And that simpler extrathoracic approach used for non-aneurysmal vessels, not sufficient if there's an aneurysm near the aorta.
Right. Open repair sounds pretty major with significant potential risks. What about endovascular or hybrid options here?
Yeah, open repair can have high rates of neurologic issues and mortality, especially in unfit patients. The thoracotomy and aortic clamping are the riskiest parts, mortality reported up to 30% in some older series.
Oh.
So combining aortic endografting with extra anatomic bypass is really attractive, avoids the big chest opening and clamping. Plus, if someone's had prior chest surgery, open might be contraindicated anyway. Recent reviews suggest endo approaches have really improved the immediate outcomes without hurting long-term results.
So what are these endo-hybrid techniques specifically for ARSA?
One common hybrid method is to occlude the symptomatic ARSA aneurysm or not using thoracic aortic endografts combined with surgically ligating the artery further down. Registry data actually shows this is the most frequent treatment now.
Covering the origin with an endograft.
Right. Getting direct surgical access to the very origin via the neck is tough, and you don't want to leave a stump that could become aneurysmal later. So a hybrid approach to the origin is used. Place an occlusion device, like a plug, right where the ARSA comes off the aorta. Can be done antegrade from above or retrograde from below. Antegrade is often preferred for better control and less risk of the device embolizing.
Okay. And the endograft covers that origin.
Yes, a thoracic endograft can exclude flow into the ARSA aneurysm, but it's often not enough on its own with current devices. You usually need to combine the TVAR with revascularization of one or both subclavian arteries.
Why both sometimes?
Because the origin of the aberrant right and the normal left subclavian are often very close together on the aorta. So placing an endograft to cover the ARSA often means you have to cover the left subclavian origin too.
Ah, collateral damage, anatomically speaking.
Kind of. Sometimes you can avoid covering the left, but blocking both subclavian origins is generally a bad idea. Risk of subclavian steal, arm ischemia, spinal cord ischemia, stroke.
Right, so you need to reroute the blood flow first.
Exactly. You might need to do bilateral subclavian transposition or carotid subclavian bypasses before the endovascular part. And sometimes the left common carotid also arises nearby, meaning you might have to transpose or bypass multiple arch vessels just to create a safe landing zone for the thoracic endograft.
Wow. That sounds incredibly complex, requiring massive planning.
It is. Very intricate planning is essential.
So what are the results like for these complex endovascular and hybrid treatments for IRSA aneurysms?
Well, the good news is these combinations have significantly cut down the morbidity and mortality compared to the big open repairs. Midterm results look pretty good survival rates, relatively few late endo leaks in some series. Tonelli's study on hybrid repairs showed the aneurysm stayed stable or even shrank over several years, which suggests good long-term potential.
That's encouraging. Are people exploring purely endovascular fixes too, without the open bypass parts?
They are. Total endovascular repair is being looked at using things like chimney grafts or branched stent grafts,
Chimney graft.
where you place parallel smaller stent grafts alongside the main aortic graft to maintain flow into branch vessels like the subclavian or carotid. There was a case report using this where open surgery was too risky. One potential issue, though, can be type 3 endo leaks between the graft components.
Okay. Other purely endo techniques.
Some have placed an endograft just within the aberrant vessel itself to exclude the aneurysm, or used an endograft to seal an aortic dissection tear originating from an ARSA. Hopp described a neat approach using Amplatzer occluders like plugs to block off the aneurysm at both ends while keeping flow in other vessels. That lets you wait and see if the arm actually needs revascularization later.
Fascinating stuff. Clearly a rapidly evolving field for these rare but complex aneurysms.
Yeah.
Okay, let's move further down the arm now. Axillary artery aneurysms. These seem mostly trauma-related.
That's generally true, yeah. Axillary artery aneurysms are pretty rare overall and usually caused by blunt or penetrating trauma. Congenital ones are reported, but infrequently. Post-traumatic ones are often seen in young men involved in activities with repetitive, forceful arm extension. Think baseball pitchers.
Ah, the repetitive stress again.
Exactly. The suspected mechanism is repeated compression of the axillary artery, damaging the inner lining, intima, leading to clot formation and eventually aneurysm development.
Like wear and tear in a specific spot. What about pseudoaneurysms there, false aneurysms?
Those usually come from penetrating trauma, but blunt trauma can do it too, things like humeral fractures, shoulder dislocations. Because diagnosis can sometimes be delayed, they often present later as chronic false aneurysms.
Does the arm lose blood flow easily?
Not always. The collateral circulation around the shoulder is usually pretty good, so distal perfusion can be maintained even with a significant injury. But the big risk with these is serious, potentially permanent nerve damage. Hemorrhage into the axillary sheath, the tissue around the vessels and nerves can compress the brachial plexus.
Nerve damage is the main concern then. How are these diagnosed?
Arteriography is strongly recommended for any significant penetrating trauma to the shoulder arm, or blunt trauma with abnormal pulses. Even blunt trauma with normal pulses but signs of brachial plexus palsy warrants angiography, as vascular injury is more likely.
Okay.
Duplex ultrasound is also reliable for diagnosis. And if someone had blunt trauma, seemed okay initially, but later develops brachial plexus neuropathy, you need advanced imaging DSA, CTA, or MRA to look for an expanding chronic pseudoaneurysm.
Got it. You also mentioned something unusual, crutch-induced aneurysms.
Yes, that's a specific type seen typically in older patients who've used crutches long-term. When examined pathologically, these aneurysms show signs of chronic trauma. Thickened walls, rough intima, severe damage to the elastic fibers in the artery wall, lots of scarring around it. Doesn't look like typical degeneration.
So the crutches themselves cause damage over time.
That's the thinking. Clot often forms on that damaged lining, and continued crutch use can dislodge it, causing emboli acute, chronic, or recurrent. Sometimes the whole aneurysm clots off by the time symptoms appear. The most common presentation is upper extremity ischemia. So you suspect it in a long-term crutch user with an absent brachial pulse.
Interesting subtype. Okay, treatment for axillary artery aneurysms. Sounds like open surgery is a main option.
Yes, open surgical treatment is generally quite straightforward for these. Usually involves resecting the aneurysm and putting in an interposition vein graft to restore flow.
Using the patient's own vein.
Preferably, yes. Meticulous care is needed to protect the brachial plexus and surrounding vessels during the operation. Prosthetic grafts are an option if vein isn't available, but autogenous vein, usually saphenous vein from the leg, is preferred for upper extremity repairs because it tends to stay open longer. Sometimes adjacent axillary or brachial vein has been used, but there's a risk that vein could become aneurysmal later. Saphenous is usually the go-to.
And the outcomes.
Perioperative risk is usually minimal, and long-term results are excellent. Some reports show 100% graft patency over significant follow-up. Presenting symptoms generally resolve unless there was pre-existing paralysis from nerve damage.
Good outcomes then. What about endovascular treatment for axillary aneurysms? Is that an option too?
It is, yes. Endovascular repair of axillary artery aneurysms and pseudoaneurysms has been reported. Usually, just placing a stent graft across the aneurysm is enough to exclude it from circulation.
Cover it from the inside.
Exactly. Occasionally, you might need to embolize side branches with coils to prevent retrograde undoleak blood feeding back into the sac from smaller vessels. But the published series are small, and follow-up is often limited. A literature review on endomanagement of axillo-subclavian injuries showed high technical success, but variable follow-up and overall patency.
So still emerging data.
Somewhat. But it offers encouraging results, and endovascular repair is definitely a potential alternative to open surgery, especially for high-risk patients with major comorbidities.
Okay. Moving further down the arm again, brachial artery aneurysms. What causes these typically?
These are most often false aneurysms, pseudoaneurysms from repetitive trauma or iatrogenic causes medical procedures. A growing association recently is with creating arteriovenous access for hemodialysis.
Ah, the dialysis access connection again.
Yes. Occupational or recreational activities can also be involved. Sometimes no cause is found idiopathic. Blunt trauma, like compression or contusion, can do it. Penetrating trauma causing tears leads to pseudoaneurysms. 4V drug abuse is a big cause of infected pseudoaneurysms, especially in the crook of the elbow, the antecubital fossa.
Right.
Frequent arterial catheterization increases the risk. And as mentioned, the dialysis access creation can sometimes cause the donor artery itself to degenerate and become aneurysmal. True brachial artery aneurysms are less common, but can be linked to things like Ehlers-Danlos type 5, Kawasaki syndrome, Berger disease, Kaposi sarcoma, cystic adventitial disease, or dissection. So again, a real mix.
A real mix indeed. How do these usually present? What symptoms do people notice?
Most patients present with symptoms of median nerve compression because the nerve runs right alongside the artery there, or just local pain.
Nerve pressure causing symptoms.
Often, yes. Other symptoms can be hand or finger ischemia due to the aneurysm thrombosing or sending clots downstream. Diagnosis is often made on physical exam. The patient or doctor notices a pulsatile mass. Duplex ultrasound confirms it easily.
Do you need angiography?
Usually, yes. Upper extremity arteriography is typically needed to see the full extent, check for other blockages, and spot any anatomical variations before planning surgery. The exception might be simple iatrogenic false aneurysms, where the diagnosis and extent are clear from ultrasound.
Okay. And what's the recommended treatment approach? Repair usually needed.
Generally, yes. Although some have been watched safely without surgery, it's hard to predict which ones will cause problems. Given the potential for complications and the relatively low risk of surgery here, aneurysm repair is usually recommended for medically fit patients.
So repair is preferred. What do the surgical options look like?
Open surgical repair is the standard, usually done under local, regional, or general anesthesia. Options include resection, followed by either patch angioplasty using a patch to widen the artery or interposition vein grafting.
Replacing the segment with vein.
Right. Sometimes, resection and direct primary anastomosis sewing the ends back together is possible. For simple iatrogenic false aneurysms, just evacuating the hematoma and doing a direct suture repair might be enough. Studies looking specifically at brachial aneurysms linked to dialysis fistulas show good patency rates with resection and either anastomosis or grafting.
Has endovascular treatment made inroads here, like in the axillary? This sounds like open repair is still dominant.
You're right, it is. There are very few reports of endografts for traumatic brachial injuries, and really only a couple of case reports specifically for brachial aneurysms.
Only a couple?
Yeah. One was a mycotic pseudoaneurysm after bypass surgery, treated successfully with an endograft and antibiotics. The other was an aneurysm after a gunshot wound, also treated with an endograft. So while it's technically possible in very select cases, endovascular repair is not currently a mainstream approach for brachial artery aneurysms. Open surgery remains the mainstay.
Okay. You mentioned iatrogenic injuries, again from medical procedures.
Mm-hmm.
How do those typically present and how are they managed?
Brachial artery pseudoaneurysms from access injuries, angiography, caths, interventions are actually a fairly common reason for needing upper arm artery repair. Though it's worth noting, thrombosis, clotting off the artery, is probably more frequent after these procedures.
Okay.
Percutaneous access has mostly replaced surgical cut-down for brachial access, but pseudoaneurysm rates remain pretty low, similar to femoral access. Accessing the artery distally, near the elbow crease, is generally preferred because the artery is less mobile there and easier to compress afterwards.
How do you spot one?
Suspect a pseudoaneurysm if there's a mass at the puncture site, signs of distal embolization or blockage, or neurological symptoms from nerve compression. Duplex ultrasound usually diagnoses it.
And treatment.
Non-operative treatment, just watching, might be okay for very small asymptomatic ones that look like they'll clot off on their own. But most symptomatic iatrogenic brachial pseudoaneurysms should be surgically repaired, usually under local or regional anesthesia, because you can't predict if they'll expand. Direct suture repair after clearing out the hematoma is usually sufficient.
What about that thrombin injection method used elsewhere?
It's generally less favored for brachial pseudoaneurysms. They're superficial, often have short necks, making injection trickier and potentially riskier. If it is used, it needs small needles, less thrombin than in the leg, and careful ultrasound guidance. Surgery is often simpler and safer here.
Okay, makes sense. Finally, let's touch briefly on aneurysms way down in the distal upper extremity radial ulnar digital arteries.
Right. Most aneurysms way down there are, again, pseudoaneurysms, usually from trauma, arterial access procedures, or related to dialysis access, just like the brachial.
Same pattern.
Pretty much. Less often you see sporadic causes like neurofibromatosis, Bassett disease, or idiopathic ones. Primary treatment is usually surgical ligation, tying it off, or reconstruction, depending on how good the collateral flow to the hand and fingers is. Can you sacrifice the vessel or not?
Okay.
Endovascular coil embolization can sometimes replace surgical ligation. And we should quickly mention Hypothenor-Hammer syndrome.
What's that?
It's a specific condition caused by repetitive trauma to the ulnar artery at the wrist, often from people literally using the base of their palm, the hypothenar eminence, as a hammer. This can lead to aneurysmal changes in the ulnar artery there.
Wow. Using your hand as a tool causing an aneurysm.
It happens. So yeah, even down in the hand and wrist, these things can occur, often linked to specific trauma or procedures.
Well, this has been an incredibly thorough deep dive. We've really covered a lot of ground, from the arch vessels down to the fingers. It's a surprisingly varied world, isn't it? Upper extremity aneurysms.
It really is. And while maybe less common overall than, say, abdominal aortic aneurysms, these conditions affecting the arm arteries and the vessels leading to them present such a diverse range of scenarios. Different causes, from degeneration and trauma to these fascinating congenital anomalies.
And it really highlights how being aware of the symptoms, even unexpected ones like hoarseness or swallowing difficulty, is crucial for potentially catching these things early.
Absolutely.
It's also genuinely encouraging to hear about the constant evolution in treatment, both refining the traditional open surgical techniques and developing these less invasive endovascular and hybrid approaches.
Definitely. The field is always moving forward. And the information we've discussed today, drawing from Rutherford's, really provides a solid foundation for understanding these complex vascular issues and the options available.
So perhaps a final thought for you, the listener, to mull over. Given the increasing use of interventional procedures everywhere, in medicine catheters, access lines, diagnostic tests, how might that trend continue to shape the future incidence and management of these iatrogenic upper extremity aneurysms? What's the ongoing balance we need to strike between embracing technological progress and carefully managing the potential vascular complications that can arise even in our arms? Something to think about. Thanks for joining us for this deep dive.